Thank you for inviting me to talk today about iron deficiency management with supplements and infusions. I'm Dr. Khamisa. I'm an assistant professor at the University of Ottawa, and I'm a consultant hematologist at the Ottawa Hospital. These are my disclosures. I do receive speakers' fees from Pfizer Canada. The action plan today for iron deficiency anemia is for you, potentially the patient or the healthcare provider, to recognize the symptoms of anemia, to understand what some of the causes might be, to understand some of the tests that need to be run in order to diagnose anemia. And these tests are the hemoglobin and the iron levels. To think about iron supplementation, both in terms of oral iron supplements and intravenous iron supplements. And our ultimate goal at the end of the day with patients with anemia is to get them feeling better, but also to avoid red blood cell transfusions if we can. If they're needed, we will use them, but we're going to talk about ways to potentially avoid the use of blood transfusion. So what is anemia? Anemia simply refers to when the body doesn't have enough red blood cells or enough of the molecule in the red blood cells to carry oxygen around. That particular molecule is called hemoglobin, and it's very important. It's so important that we define anemia by the actual number of hemoglobin molecules. That's what we measure rather than the red blood cells. When that number is low, we have anemia. And when that number is low for the hemoglobin, and when there aren't enough hemoglobin molecules that are due to low iron, that's called iron deficiency anemia. And just to give you an idea of how important iron is in hemoglobin, there's 4 iron molecules in each hemoglobin, and it's so important and such a major component of the hemoglobin molecule that most of the anemia worldwide is actually due to low iron. There are symptoms of iron deficiency anemia that some of you might be familiar with. The more intuitive ones are when you have fatigue, and sometimes it's extreme fatigue, weakness, chest pain for more severe anemia, shortness of breath, heart palpitations, feeling faint. Some folks even have symptoms where they crave ice or crunchy things. That's called pica. You may have thinning hair, headaches, pale skin, nail and skin changes and mouth changes and ulcers or an inflamed tongue. Some folks even get restless leg syndrome, and that can be very disturbing where the legs start kicking at night. That happens with the very low iron level as well. Iron deficiency anemia affects over 1 billion people in the planet. And most of the anemia in the world is actually iron deficiency anemia. So some of the causes of iron deficiency predominantly revolve around women's health and menstrual health. So women with very heavy periods are very prone to iron deficiency anemia. And this also occurs when women have moderate or light periods, but aren't balancing in the amount of iron that they take in. So sometimes it's a combination of things. Sometimes patients can have low iron due to gut health conditions, such as Crohn's disease or celiac disease. Some patients may have surgeries that prevent absorption of iron, such as a gastric bypass surgery. And during pregnancy, iron demand increases tremendously as women not only need iron for themselves, the growing baby or the fetus needs iron, and the placenta needs iron. So there's 3 reasons for iron to be low in pregnancy, because those 3 entities, mom, baby, and placenta, need iron. So that's just something to be aware of if you're pregnant. And that occurs mostly in 3rd trimester of pregnancy. So in terms of a conversation germane to the group of patients that may have hemophilia and bleeding disorders, those particular patients are very prone to heavy menstrual bleeding. As you may be aware, heavy menstrual bleeding may be one of the most first or prominent symptoms in a very common bleeding disorder called von Willebrand's disease. So those women with heavy menstrual periods are very at risk for iron deficiency and iron deficiency anemia, as the blood that they're losing has hemoglobin and iron molecules, and all of that's leaving the body. This is the age distribution of women with heavy menstrual bleeding. We can see a couple of peaks, a little bit earlier on and a little bit later on in life too. What blood tests would your physician run if they suspected iron deficiency anemia? Well, we've mentioned the molecule hemoglobin a few times, and that's a particular blood test that can be run as part of a bigger blood test called a CBC, or a complete blood count. And when you see that on a blood work requisition, you know that your doctor is trying to check for one of the things that they might want to check for is anemia. And if they see a hemoglobin of less than 120 in a non-pregnant female, or if they're pregnant, usually less than 110, we suspect that there could be iron deficiency or at least anemia. And in concert with that, if the iron level, a level called the ferritin, is low, if it's less than 30, if those two things happen together, that pretty much clinches the diagnosis of iron deficiency anemia. There could be other reasons to be anemic at the same time. B12 levels might be low. There may be some elemental cell breakdown, or there may be some inflammation. In those cases, when we can't use the ferritin level alone, some physicians use another value called transferrin saturation to help assist in diagnosing iron deficiency anemia. And if that number is less than 20%, then we also might have either an absolute iron deficiency anemia or what's called functional iron deficiency anemia. But your physician would be in a good position to interpret the values and help you interpret them as well. So our goals with iron deficiency are to prevent it in the first place. If you're high risk, one of the first things you can do is look at your diet. Now, I will say that dietary measures alone are best used for prevention and maintenance. Once a significant iron deficiency anemia has been treated, sometimes diet alone can help prevent future relapses. But in and of itself, it's very hard to take in that much iron if you've already been diagnosed with significant iron deficiency anemia. For prevention, though, you want to take in at least 8 to 27 milligrams of iron per day. Now, that number is going to be more on the 27 side if you're pregnant, and on the lower side if you're postmenopausal or if you're a male. So there is a range in there, and these numbers are freely available on the Health Canada website. In order to prevent iron deficiency, there's different types of iron that the body will take in, and there's different absorption rates for these types of irons. So one type of iron in food is called non-heme iron. And while this is most of the iron we're going to consume, the body doesn't do a great job in absorbing it. Only 10% of that iron really gets into our body from the little label we see in terms of the number of milligrams. We actually have to do a little calculation in our head indicating that we'll probably only get about 10% of that. If the type of iron you're consuming is from legumes, let's say lentils are actually a very good source of iron, and just the amount of it's so big, even with the lesser absorption, you're actually getting a really good amount of iron sometimes. Pumpkin seeds, eggs. Now, the tricky thing with this non-heme iron is that it's very susceptible to being decreased absorption, having a decreased absorption even less because of other things. Coffee, tea, certain medications, dairy products. So if you're really trying to boost your iron in your food, just be careful if you're washing things down with a cup of tea after whatever iron-rich meal you might have had might have some less absorption because of those other things. So there are some strategies that you can utilize to sort of offset that. And some clinical studies, not all, have shown that vitamin C can help absorption of iron from non-heme iron sources. And a glass of orange juice with your iron tablet sometimes has been recommended, just as one study did show that that can boost a little bit more of the iron. Now, in terms of the meat products, I know many of us are avoiding or reducing the amount of red meat. But even if you are, just any meat source might have a little bit of better bioavailability of iron, not just red meat, but fish, poultry. And the body absorbs that a little bit better. About 40% of that iron is absorbed. So we'd want to consider, thinking about mixing heme and non-heme iron and enhancing absorption with vitamin C rich foods. Kiwi fruit is an excellent source of vitamin C and also prevents constipation, which can happen with iron tablets. So there are a few tips and tricks to really get a big boost of iron from our diet alone. If some folks are avoiding different types of food and they prefer to take things with a multivitamin and iron, just look for the multivitamin with about 20 milligrams of elemental iron if you've been diagnosed with somebody or you think you're somebody at risk. So in terms of what we want to do in terms of treatment outside of diet, we want to boost our red cells, we want to boost our hemoglobin, we want to replenish iron stores, and we want to think of ways outside of diet to perhaps boost our iron and our hemoglobin levels. And we can do so in a couple of ways outside of diet. Oral iron supplements, so pills. Intravenous iron, that's where a small needle goes into the vein and a little bag of iron. It's not a blood product, it's not a transfusion at all, but a little bag of elemental iron will be infused inside the blood. And then our last option is blood transfusion, and that's for more severe anemia or symptomatic anemia. Perhaps if there's a lot of ongoing bleeding, we might consider that. And that's valuable in those contexts, but otherwise we try to avoid that. In terms of the iron supplements, there's so many that you can get. And in Ontario, at least, iron tablets are available without prescription. They're not exactly in front of the counter because there are some risks with children taking too much iron tablets. If it looks like candy, they may swallow that, and that can cause some problems. Pharmacists in Ontario keep iron tablets behind the counter, but you don't need a prescription for the most part to get them. It is ideal if your physician does write a prescription. That will mean that the pharmacist knows the exact dose, the other medications that iron might interact with, and drug plans may cover that particular prescription. Not all, but some do. So it's better if your physician is able to actually write something on a prescription for you to take into the pharmacy. The pharmacist will also just grab something off the shelf and offer it to you. And there's a range of prices. And not every expensive iron supplement equates with the best iron supplement. Some of the cheapest iron supplements, oral iron supplements, and the best and most effective that have been studied in clinical trials, head to head with more expensive ones, actually do better in terms of absorption and performance. And the one that I'm thinking of is ferrous sulfate. There's been many clinical trials in the past 5 years comparing ferrous sulfate. Sometimes it's taken every day, sometimes every other day, but compared to some of these expensive ones, very definitely just as effective. The issue with these iron salts is that they cause, and they're the cheapest types of iron supplements, ferrous gluconate, sulfate, fumarate, bisglycinate, that they cause stomach cramping sometimes, diarrhea, sometimes constipation, sometimes nausea, sticky green stools. So you have to be very careful in terms of when you're first starting, monitoring your symptoms and feeding, if you're really not tolerating the iron supplement, to feed that back to your provider, your physician, or your nurse practitioner to make sure that they switch formulations or think of another strategy for you. Now, in terms of moderate, inexpensive iron supplements, iron salts are the most inexpensive, followed by a type of product called iron polysaccharide or triferics, which is a more generic version of Ferromax, which is can be expensive, or Polyride. The iron polysaccharides are better tolerated than most of the other kinds of iron salts. The issue being they're expensive, and in head-to-head clinical trials, at least in children, their absorption was shown to be less than ferrous sulfate. There are even more expensive iron supplements out there. Some are based on heme iron. So the fact that that better bioavailable iron, you can capture that in a small tablet. So those particular brand names are shown, Hemifort, Optifer, Proferin. And there's even more newer iron supplements. And some of these are up to $4 to $5 a day to take these supplements if you have it in your budget and you don't want to worry about food interactions. This newer product called Ferrocell Forte may actually be helpful. Now, I did allude to some of the side effects. And these side effects include nausea, constipation, and dark stools. Ensure you're well hydrated when you're taking oral iron, especially the oral iron salts. You may wish to take some vitamin C, either in your diet or in tablet form, potentially to help with absorption. Avoid dairy products, coffee, tea. Often there's a spacing of an hour or two. Studies have shown best taken in the morning for iron tablets, but again, not everybody can do that with their schedule. So take it consistently when you can. In terms of just starting iron tablets, you may wish to take iron tablets every other day, just to begin with, to see what the side effects are, and then move to daily pretty quickly if there are no side effects. And you may wish to take a laxative or magnesium citrate at night, and that can also serve as a little bit of a laxative to if there's any sort of hard stools that come along with taking iron. And tracking apps, pill dispensers, those have all been shown to increase compliance. So sometimes a little alarm on the phone to take your iron every single day, those can help. And this is a small algorithm that I use in my clinic just to help clinicians especially know what particular type of iron to start with. I always start with something like a ferrous sulfate, may want to add some vitamin C, look to see if, patients are tolerant. If not, we move to every other day. We sometimes try more expensive types of iron. And then we would want to check the parameters, the hemoglobin levels, and see that they're rising little by little by little, even if it's slow. And as long as there's no surgery or major bleeding going on, we can work slowly with iron tablets. And usually by the 2 to 3 month mark of consistently taking iron tablets, people are often normal with their hemoglobin. Their iron stores might be down, but at least they're not anemic anymore. And then it may take a further 3 months after that to replete their iron stores. The underlying a cornerstone, though, of management would be to ensure the underlying bleeding issues are addressed. So that probably would be another seminar or webinar altogether on how to manage heavy menstrual bleeding. And again, if folks find they're intolerant, there are these newer oral iron supplements available. But again, I don't jump to them right away. I let people try the iron salts first. If patients are intolerant of oral iron, all kinds, or they're in a bit of a rush to get their hemoglobin levels up, this often happens when folks are waiting for surgery. So we want to try to get iron levels up a little bit quicker. We do so with intravenous iron, and we've had some form of intramuscular intravenous iron available in Canada at least for 40 years. So in each particular generation of IV iron, or parenteral iron is a fancy name for it, each particular generation gets better and better and better in terms of how easy it is to give, the number of visits that patients have to get the intravenous iron. Everything's becoming a lot more streamlined, and clinicians are a lot more aware of how to give IV iron, the side effects profile. The profiles of all of the different intravenous irons have improved over time. And we prefer to give at our hospital a single dose, unless the patient's pregnant, of intravenous iron. And that in 2018 was licensed as iron isomaltoside, now called ferric maltose. Another name is monoferric. And that is a higher dose of intravenous iron that we use in our non-pregnant patients. And it typically just means 1 or 2 visits, as long as there's no ongoing bleeding. Sometimes patients get the 1 to 2 doses. They don't need another one sometimes for another 2 years. I've seen a dose given every 3 years sometimes. So it's a larger amount of iron that goes directly into the vein. And usually patients with significant anemia have at least 1,000 milligrams of iron that they're going to need somehow, some way. And we can give it with intravenous iron pretty quickly. Some at our hospital just get the single dose of monoferric or ferric maltose, but some clinicians are giving the smaller doses of IV iron, which need about 5 visits given every 2 weeks. That's our pregnant patients. Sometimes they get this product called iron sucrose or Venifer, and everything in between. It really depends on the clinician. Now, the hospitals are very good at knowing how to give IV iron, monitoring for side effects, etc. They're really safe. They're much safer than they had been 30 to 40 years ago. Now, in order to just give a comparison, if your body is deficient of 1,000 milligrams of IV iron, you would need to eat 500 steak dinners in order to correct that deficit. Or you could do so slowly over 6 months with 165 tablets of ferrous sulfate. And a course of 165 tablets of ferrous sulfate is only $10, $10 to $15. So really, it's a cost-effective but slow way to correct your iron deficiency anemia. And in some folks, that's perfectly acceptable. There are some practical aspects. If you've been prescribed an iron infusion, there's a lot of trepidation and a lot of questions about what to expect. The physician who's prescribing the IV iron will often give a lot of information to you about risks. There's very little risks. The side effects may be feeling a little bit of hotness and flushing. Some people do get allergic reactions. That's really rare. But some people do get itchiness or hives, or the vein that the IV iron is given into can sometimes lodge a little bit differently. So there may be a bit of a burning at the vein where the infusion is going in. Most IV iron is given at a hospital. However, there are many private infusion clinics. Family physicians can actually access these private infusion clinics as well, at least in Ontario, and nurse practitioners. So you really don't need a hospitalist-based physician to get intravenous iron. Now, there are some questions about funding that would need to be asked. Does your drug plan cover the intravenous iron? What are the provincial funding models? At least in Ontario, we have 2 funding models for intravenous iron. Some hospitals just have a compassionate program. And to correct, your iron deficit, if you've got a significant anemia, the cost, at least in 2024, of 1,000 milligrams of IV iron is around $450. And these are some of the symptoms that may be experienced. They're less than 3%. And most of the time, the nurses at the day unit where the infusions are given are very well aware of what to do. But when some patients arrive home, they feel a little bit of a flu-like symptom or a little bit of fatigue. Ironically, people think I thought my iron infusion would give me a boost, but some patients note a little bit of fatigue the day or 2 after, sort of a flu-like syndrome. And then after that, it disappears, and they feel quite a bit better a week or 2 after their infusion. And in terms of access to IV iron, iron deficiency anemia predominantly affects women. 80% of my patient load who are iron deficient are female. or females, predominantly females who have menstrual cycles. So access to this drug can vary across Canada, but this is, I see, a gender equity issue in the sense that most of my patients are women or identify as female, having heavy menstrual periods. And this is another form of what I call a pink tax. That's my own personal view, where now, in addition to paying for menstrual products, tampons, etc., the cost of this intravenous iron is borne by predominantly women. And so I have been asking my MPP to get involved with this issue, and she has indicated she would be bringing this up at the provincial level. And if you have access to your hospital administration, or you're finding there's barriers to accessing IV iron, please to write to your hospital administrators, tell them about your story, write to your local MPP, and bring this up as an issue. So I hope that I've given you some insight about iron deficiency anemia. This is a very common problem in women with heavy menstrual bleeding. I hope that I've taught you to recognize some of the symptoms, understand some of the causes, understand some of the blood tests that may be run to help you diagnose the iron deficiency anemia. Think about oral iron supplements, especially if you're a high-risk individual. Not everybody with anemia has low iron, but that's going to predominantly be the cause in many patients with anemia. If iron supplements don't work, and 30 to 60%, there's a big range of patients that really won't tolerate oral iron tablets. And no matter how much you try to do different things to get patients to tolerate the oral iron, it just doesn't work. In that case, think about intravenous iron. I'm hoping that unless, patients really need that red blood cell transfusion for iron deficiency anemia, I'm hoping that we can have our clinicians and our patients really well aware to avoid red blood cell transfusions. And there's many, many reasons for that. Clearly, if you need one, you should get one. But if you can avoid it, that will help in female patients who receive young menstruating, fertile patients that are hoping to have children. If they do receive blood transfusions, there's a possibility of antibodies being built up that may affect future pregnancy. So that's one reason. The second reason is the side effects of red blood cell transfusions themselves are infection, allergy, transfusion reactions. Number three, the cost of blood and the accessibility of blood it's very, very low to our stores sometimes of red blood cells are very, very low in the blood bank. And the cost to procure a unit of blood is around $800 when you factor in all the virus testing that needs to go into making sure our blood supply is safe, all the administration, storing the blood in blood bank, the time for the blood donor to actually get to the blood donation, take time off work. When they factor that in, it's actually very, very expensive to give blood transfusions, and it has more side effects than other therapies such as oral iron or IV iron. So really, unless you need them, I'm hoping that we can avoid that. If you're looking for more resources about heavy menstrual bleeding in particular, this is an excellent resource from University of Toronto affiliated professors. And this is gyneqi.com. There was a large launch, social media launch, YouTube, website, other types of socials. So I would highly recommend these resources. They're both patient-facing and clinician-facing. I find them excellent. And in terms of diet and getting more iron into your diet, the Dietitians of Canada also have a very good website. And again, this is probably more for prevention and maintenance once your iron's been corrected. And the Ontario Midwives Guide to Oral Iron gives you a more detail than I've given probably in this presentation about different types of elemental iron in different iron supplements. So that is another useful tool as well. Thank you so much for inviting me to talk today, and thank you for your attention. I'd be happy to answer questions offline if they arise. Have a great day.